The following podcast is part of a certified educational activity titled Implementing Targeted Therapies in Transthyretin Cardiac Amyloidosis from Diagnosis to Stabilization. Access the entire activity and complete the post-test at peerview.com/FRU860. Downloadable slides and practice aids are also available.
Welcome to Implementing Targeted Therapies in Transthyretin Cardiac Amyloidosis from Diagnosis to Stabilization. So, panelists, as you can see, me and my awesome colleague, Senthil Selvaraj. So our goals. Number 1, raise your index of suspicion for the signs and symptoms of ATTR cardiac amyloidosis. Equip you with strategies for prompt diagnosis and treatment. Provide guidance on individualizing treatment regimens for ATTR-CA, incorporating the most recent evidence. So bottom line, we are going to make you care about it, be excited about it, and go out and save lives of people with it. So I'm going to start first with a master class on improving recognition and diagnosis of ATTR-CA. That picture kind of looks like me. I was a few years younger then, but it is me. Okay, so what is transthyretin? Let's take a step back. We all know cardiac amyloidosis is a condition where there's a protein the body produces naturally that, for reasons that are somewhat mysterious, decides to deposit into the heart and other places. The two most common kinds are AL amyloidosis, immunoglobulin light chains, and TTR. TTR is the one we care about today. It's a protein primarily synthesized in the liver. It does good things in our body. It transports vitamin A and thyroxine. It's also made other places, small amounts, not necessarily clinically relevant. It's also previously known as prealbumin. You could actually check a TTR level by checking a prealbumin level, which can be a sensitive indicator for malnutrition and illness. So when we think about cardiac amyloidosis, while there's 100 different kinds, the two you care about is if it's immunoglobulin light chains, which is a plasma cell dyscrasia along the spectrum from MGUS to multiple myeloma, and the TTR cardiac amyloidosis, which in turn has two sources, either a mutation or variant in the gene, ATTR-V, cardiac amyloidosis, or wild type. Now, in the olden days, we used to call that senile cardiac amyloidosis, but we don't do that anymore. It hurts people's feelings. Instead, we say variant and wild type. And very important that the protein just doesn't go to the heart. It can go other places as well, which is hugely important when you think about diagnosis. There could be nephropathy unique to AL, neuropathy, gastrointestinal involvement, orthopedic issues in all of them. Now, what about these variant forms? Why should you care about them? A lot of reasons you should care about them. There's multiple pathogenic variants implicated in ATTR-V, some that have predominant neurologic features and some that have predominant cardiac features. V142I or 122I is the one you will see most commonly in the United States. In fact, 3.5% of Black Americans carry this variant. And Dr. Selvaraj has done amazing research on this, which he'll tell you about in a little bit. That's foreshadowing and a little to keep you excited. But 3.5% of Black Americans will not all get ATTR-CA, but it means you raise your index of suspicion in that population. There's also some other geographical preferences for various variants. So, what do you need to know? You need to know that heart failure symptoms are the tip of the iceberg in patients with ATTR-CM, and you have to be aware of what lies beneath. They can have more nonspecific symptoms like fatigue, other cardiac findings, AFib, AV block, pacemaker, aortic stenosis, or HFpEF, which is essentially a diagnosis of exclusion. There might be an underlying cause for which there's disease-modifying therapy. In case series, about 15% of patients older with severe AS or HFpEF have concomitant or underlying cardiac amyloidosis. Don't miss the diagnosis. Patients can have more than one problem. Think about that increased LV wall thickness, and it doesn't quite match the QRS voltage. Sensory neuropathy, autonomic dysfunction. Classically, you give them a little vasodilating antihypertensive, and they start fainting. That smells like autonomic dysfunction. Think about carpal tunnel, spinal stenosis. And when you think about these things, they are seen very frequently. It can be an incidental finding accompanying other cardiac diagnoses. Maybe someone thought the patient had HCM, hypertrophic cardiomyopathy, but that increased LV wall thickness was actually ATTR-CM. Okay, so now we're going to go to Practicum 1, still me, where we're going to talk about the step-by-step guide to evaluating a patient, and I will lean on Dr. Selvaraj for his wisdom. Okay, let's talk about a patient because everything is more interesting when we talk about a patient. Leonard, a Black man, age 73 years. He presents to the ED with progressive shortness of breath, about a month, shortness of breath at rest, orthopnea, so this is getting progressive, lower extremity swelling. On exam, not a medical mystery, elevated JVP, bibasilar Ralls, irregular rhythm, 2+ edema. Blood pressure is okay, tachycardic, temperature's fine, and he's hypoxic. He's needing some supplemental oxygen. Creatinine's not good. Liver enzymes are up, probably hepatic congestion. His NT-proBNP is up. His other history, hypertension, coronary disease, EF is 45 to 50% on echo, increased left ventricular wall thickness. Stress test had looked fine. Mysteriously, 2 older brothers and his father had heart failure. He takes aspirin, rosuvastatin, amlodipine. So, Dr. Selvaraj, what jumps out at you in this case?
Yeah, I'd say a few things. So first of all, that family history is obviously very suspicious. And so we think about ATTR, for example, and variant-related disease, it's autosomal dominant. And so there can be a really significant history of heart failure whenever you look at family members and do cascade screening. The increased wall thickness, of course, always catches our eye. How much it's increased is obviously going to be important as well. And so in an individual who has hypertension, trying to at least mentally match their blood pressure with that wall thickness is going to be important. But we would say that if you have a very significantly increased wall thickness, for example, greater than, let's say, 18 millimeters, that's very unlikely to be hypertension at that point.
Amazing. And it's so important not to write things off. Well, he's a older Black man. Guy's got hypertension. It's all got to be that. Look deeper. Think about what doesn't fit. This family history, this mildly reduced low normal ejection fraction. What's going on? And that brings us to the red flags for cardiac amyloidosis. It's kind of the tip of the iceberg. What lies beneath we talked about before, but reinforcement is so key. Think about that LV wall thickness that doesn't quite fit your clinical picture. Think about this persistent low-level troponin elevation. How many patients who ultimately have cardiac amyloidosis got an angiogram that showed nothing because their troponin was high, because the amyloid is infiltrating their heart, that BNP is elevated? And think about these extra cardiac manifestations where you have seemingly disparate findings that lead to a satisfying, unifying diagnosis. Listen, 10 years ago, my patient told me when I was 60, I had bilateral carpal tunnel surgery. I was like, fine, I'm a cardiologist. Now, huge red flags. That's the beauty of medicine, right? So feel that tingle on the back of your neck. It's not cervical spinal stenosis because you have cardiac amyloidosis. It's because you're thinking, what is the problem here with bilateral carpal tunnel, spinal stenosis, biceps tendon rupture, neuropathy? Put it all together. And so, when I think about patients with shortness of breath or edema, it's so important to figure out, number one, is it the heart's fault? Because maybe it's a non-cardiac mimic. Maybe it's the kidney, the liver, or chronic venous insufficiency. You can't unring the bell of misinformation, right? If you tell a patient they have heart failure, they will think forevermore they have heart failure when it really wasn't the heart's fault. So first of all, figure out, is it the heart's fault? If you're convinced that the dyspnea and edema and preserved ejection fraction is the heart's fault, then you have to ask yourself, is this garden variety HFpEF? Or is it a condition for which there is actually disease-modifying therapy, like HCM, pericardial disease, valvular disease, high-output heart failure, or most importantly, infiltrative cardiomyopathy like amyloidosis? Now, I am never one to argue for more testing, but I will always argue for more thinking. So when that patient comes to you with dyspnea, edema, and preserved ejection fraction, you ask yourself first, is this my problem? Is it the heart? And if you are convinced it is, then ask yourself, should I be looking for a HFpEF mimic? Does this patient warrant more testing based on those red flags? Now, one of my pet peeves in life, and I have many, is when an echocardiogram report says LVH. Wait a minute. The walls are thick, but do you know it's muscle that's making it thick? Because left ventricular hypertrophy, by definition, is the muscle is thick. But if the report says LVH, then already you're anchoring yourself away from half the reasons you can have LVH. So reorient that in your mind, or if you do echo reports yourself, change it always to increased LV wall thickness with no judgment on what the source could be, and ask yourself, is it too much muscle, explained or unexplained, or is it infiltration into the muscle? And by far, I mean, Fabry's I've seen a few times, Danon less, but amyloid is going to be by far the source if you think there's infiltration. Now, why must AL amyloidosis be evaluated before diagnosing ATTR? So I told you before, the two most common times you're going to see in the heart are AL and ATTR. AL is way more common. I mean, ATTR is way more common, but AL is way more deadly. And if you look in echo, you can't tell the difference. If you do an MRI, you can't tell the difference. And here's the scary thing. We'll talk about the technetium scan, the radionuclide scintigraphy scan. In 10 to 20% of patients with AL, it can be positive. So while that scan is ostensibly diagnostic for ATTR, and it is, only in the presence of a negative screen for AL. Because say you see a patient and you're like, I'm going to do this scan on you because it's easy. And now the scan is positive, and look, I've diagnosed you and I'm going to give you a medicine. But they actually had AL. What's the median survival of untreated AL cardiac amyloidosis? Don't worry, I won't call on anyone. I'll tell you, it's less than a year. So you would never want to miss that diagnosis. In fact, to a cardiologist, it's a medical emergency. So here is the 3 plus or minus 1 tests you need to always make the right diagnosis. And unlike things like pulmonary hypertension, which is really complicated, amyloidosis is not. It is very straightforward. So you have your clinical clues. You passed the first challenge. You had a high index of suspicion. But you won't find it if you don't look for it, and you won't find it on routine testing. So first step, you will do a monoclonal protein screen. If the monoclonal protein screen is abnormal, you do not pass go, you do not collect 200. You remember that tissue is the issue and you biopsy something. But if the monoclonal protein screen is negative, you take a big, deep sigh of relief because you're very happy for the patient, and you do your radionuclide scintigraphy scan, most commonly technetium pyrophosphate, and if it is positive, you have 100% accuracy diagnosed ATTR, cardiac amyloidosis, and then you'll do genetic testing, which is important for cascade screening of first-degree relatives. Some subtleties to this diagnostic algorithm. Now, when I was in medical school, half of what I learned was just word association. And I remember one of my word associations was SPEP amyloid, SPEP amyloid. Actually, SPEP is not sensitive enough. You must order immunofixation electrophoresis. If you truly want to exclude a light chain, you must order immunofixation electrophoresis as part of your monoclonal screen. Second, I memorized fat pad amyloid, but a fat pad has inadequate sensitivity. You might want to start with a fat pad because it's less invasive, but you cannot end with a fat pad. If your monoclonal protein screen is abnormal and your fat pad doesn't help you, you must biopsy the organ of interest as the gold standard, typically heart or kidney. And if you do the technetium scan, like I said, you must never interpret it outside the context of a monoclonal protein screen. Now, you might say to me, do you actually order the monoclonal protein screen, wait for it to come back negative, then order the technetium scan? I mean, no, I live in Southern California. Traffic is terrible. I want to get as much done as possible at that first visit. So I'll typically order all 3 at once because the chances as AL is much lower. And even if I order all 3 at once, typically the blood and urine tests will come back faster. But I think that's a good practical way. But you should never interpret your radionuclide scintigraphy scan outside of the context of a monoclonal protein screen. If you remember nothing else, if you forget that TTR is also made in the choroid plexus, I will forgive you. But don't forget the monoclonal protein screen. Now, genetic evaluation can be complex with certain cardiomyopathies. Lucky for you, this algorithm doesn't quite apply to ATTR-CM because the pathogenic variants are very straightforward. They either have them or they don't. You're not going to be muddling through variants of uncertain significance. It's a very routine single gene test. And now, I think I went 20 seconds over time. I apologize. Dr. Selvaraj, it's all you.
I forgive you. There are few greater academic joys than working with Dr. Kittleson. So thank you so much. for that outstanding presentation in the diagnosis of ATTR-CA. It is absolutely my pleasure to talk about new paradigms and treatment landscape in the contemporary era. This is a really exciting field. I think I got the better half of the session. I'm sure that you would debate me on that, but this is a really exciting time with so many changes even within the last year. So let's go back to the case. And so Leonard undergoes more diagnostic workup. We find out that he has a significantly elevated BNP and high sensitivity troponin. This is in the context of the increased wall thickness and the family history, so raised suspicion for thinking about cardiac amyloidosis. His ECG shows low voltage on his in his precordial leads as well as his limb leads. Atrial fibrillation with that irregular rate was noted. They undergo monoclonal protein screening, which is of course negative and so important, as Dr. Kittleson mentioned. And then finally undergoes a technetium scan, which shows grade 3 uptakes that was consistent with the diagnosis of cardiac amyloidosis. Anything else to note from this workup? Did we do everything that you suggested that we do, Dr. Kittleson?
Thank you so much for asking. Listen, I think it's so great. That low voltage is weird. Now, there might not be actual diagnostic low voltage. Only 30 to 40% of people have that, but there may just discordant voltage. It should be higher. So don't be dissuaded if everything doesn't fit. Look at the context. So I think this guy is pretty much a slam dunk.
Excellent. And then in your head, do you ever think about indexing for LV mass? Do you think of a number, or do you just go with a gestalt? If you really thick walls and then the voltage is so that's good enough for you.
You know, by middle age, there's only so many facts that can fit in my head. I do a gestalt.
Excellent. And so now that we've established the diagnosis of ATTR-CA, we need to start thinking about treatment. So let's talk about general treatments for ATTR. I think all of us are very familiar with the concept of GDMT and heart failure, or beta blockers, RNA ACE inhibitor, ARBs, MRAs, SGLT2 inhibitors. But we need to modify those pillars of care in cardiac amyloidosis. For example, beta blockers typically are not necessarily well tolerated because of a fixed stroke volume and an increased reliance on heart rate for that cardiac output. There are some observational data that suggest that if you have a low EF, that beta blockers may be more helpful in that setting, but these are observational data. So I think all in all, we need to treat each patient individually. I think it's more the rule that RNAs, ACE inhibitors, and ARBs are not well tolerated due to their vasodilating effects, but MRAs and SGLT2 inhibitors are very well tolerated. And I think that's been shown time and time again in a lot of the observational data. If you have atrial fibrillation, they need to be anticoagulated. So just completely forget about the CHADS2 VAS score. You need to anticoagulate because there's a very high thrombosis risk and stroke risk in these patients. So let's talk about targeted treatment. I think this is probably one of the most important aspects of care for patients with cardiac amyloidosis. So we have two classes of medications that are currently FDA approved, so 3 from them, 2 stabilizers, 1 silencer, tafamidis, acoramidis, and vutrisiran. The stabilizers work to stabilize the molecule so they prohibit or inhibit dissociation into the monomers and misfolding and organ deposition as a result. And vutrisiran is a silencer, so it decreases the production of TTR in the liver, targeting mRNA. The stabilizers are oral pills, so they are taken either once or twice daily. And the silencer is a subcutaneous injection, which is given every 3 months by a healthcare professional. Because silencers work to decrease TTR, which transports vitamin A, you need to supplement with vitamin A for the duration of treatment. So that's very important. All 3 of these have a cardiomyopathy indication, but only vutrisiran currently has a neuropathy indication, which is important whenever we think about choosing a therapy for our patients. These are very well tolerated in clinical trials with adverse events that are generally similar to placebo or maybe some GI side effects. So let's talk about the first trial that came out about 7 years ago, and this was a TRACK, which I think was a landmark in this field, and it really emphasized that now we can actually modify the natural history of the disease. So it's a study of about 441 patients with wild type as well as variant. There was mostly wild type in this study, and they were New York Association class 1 to 3, so that's important. So there were individuals who were asymptomatic in this trial. They compared 80 milligrams of tafamidis versus 20 milligrams of tafamidis versus placebo in a 2:1:2 ratio. And it was a hit. So there was a roughly 13% absolute reduction in mortality. And so if you think about an absolute reduction of 13%, that corresponds to a number needed to treat of roughly 7 to 8. If you compare that to any GDMT in heart failure, that compares very, very favorably. And there are differences in terms of cardiovascular hospitalizations and heart failure hospitalizations as well. So very favorable outcomes. They also performed a long-term extension or an open label extension. So patients who were initially randomized to placebo could switch over to tafamidis around 30 months. And I think this graph on the right really emphasizes the fact that early treatment matters. And so if you were randomized to tafamidis early versus randomized to tafamidis late, you can see that the curves continue to diverge, and maybe they'll come back and slow down at some point. But really, this emphasizes the importance of early targeted treatment and initiation. So now we get to some of the function and feel endpoints. So 6-minute walk distance in KCCQ, 76 meters in favor of tafamidis. You can see that the curves continue to diverge over time. In KCQ with a 14-point favor for tafamidis. And that's huge, right? And so if we think about the minimum clinically important difference for KCQ, that's typically around 5 for what most people consider to be clinically significant. So 14 points is a large improvement in quality of life. And I should put a caveat there. It's not necessarily an improvement, but a delay of the progression of the disease. You can see that people continue to decline in terms of the 6-minute walk time, in terms of the quality of life. And so the goal, again, is stabilization, not necessarily reversing the disease with their available treatments. Now let's go to acoramidis and the ATTRibute trial. So this was the next trial that came out about a year ago. This was a study of around 600 individuals. They were randomized to acoramidis or placebo in a 2-to-1 fashion. Again, most patients in this trial had wild type as opposed to variant. And because tafamidis was approved at this point, tafamidis was not allowed in the first year of the study. However, patients could be initiated on tafamidis in either treatment arms until it was blinded. The primary outcome was a hierarchical composite score, but needless to say, it was another win for the field. And so you can see using these data, looking at all-cause mortality, cardiovascular-related mortality, and as well as first cardiovascular-related hospitalization, significant benefit in all 3 domains. Like the first study in ATTRACT, there's an open label extension for this. And you can see that patients who were randomized to placebo first could switch over to acoramidis after. And those curves, again, continue to diverge over time, again, underscoring the importance of early targeted therapy. What is really interesting is if you look at the last slide to the right, is that these curves seem to diverge relatively early too, even within a couple months. And so if we think about when to initiate treatment, yes, it's not AL amyloidosis. It's not that emergency that you need to figure out in the next couple weeks. But really, if these curves are diverging within the next couple months, that we should be thinking about getting our patients started on therapy more quickly. So getting back to some of the other endpoints in ATTRibute, there was a large increase in serum TTR levels. It's important to note that TTR levels increase with stabilizers and they decrease with silencers. So they go in opposite effects. So a large increase in TTR levels, about 7 points, an improvement in the 6-minute walk distance, less of an increase in NT-proBNP, and less worsening of the KCCQ. So again, patients do continue to decline over time in terms of these function and feel endpoints, but less so than in placebo. And finally, the newest kid on block, this is vutrisiran and HELIOS-B. This is a study of a silencer now, so decreasing TTR levels. This is a 655 patient trial with both with largely wild type, but about 10% variant disease. And this is the subcutaneous injection, so every 3 months. The primary endpoint was a composite of death as well as recurrent cardiovascular events. You can see that there's a significant improvement in the rate of all-cause mortality as well as cardiovascular mortality and all the related events here. It's important to note that in this trial, 40% of patients were on tafamidis at baseline. So that's a relatively large percent. And so in this trial, they looked at whether you were just on monotherapy, just on vutrisiran in the trial, or whether you're on combined therapy. And so that's the first time that we ever got more data on what it looks like to have both a stabilizer and a silencer together. So those function and feel endpoints all again favored vutrisiran in terms of 6-minute walk time as well as KCCQ and quality of life, less worsening of the NT-proBNP and stabilization of troponin as well. I think this is a really nice table and figure that compares all the 3 trials together. And so these trials are all modestly sized in terms of cardiovascular trials, so about 400 to 600, and they can be modestly sized because the event rates are relatively high, or they have historically been relatively high. The average age is in the 70s, appropriate for the diagnosis of cardiac amyloidosis. They're largely men, largely self-identified white race, and largely wild type. And those 3 all sort of go together, which is why they sort of match up there. What is important to note is that the type of patient who's being enrolled in these trials has continued to change over time. And in general, there are healthier patients who are being enrolled in trials from ATTRACT to ATTRibute to HELIOS. So if you look at New York Heart Association class, there's a greater percentage with lower New York Heart Association class numbers. In HELIOS in the later trials versus the earlier trials, there's a lower NT-proBNP as we go further along and a lower NAC stage as well. And so if we compare the placebo arm, and this is the graph on the right here, the placebo arm in each of these trials, you can see that they continue to get a little bit better, so a little bit healthier over time. And actually, if you look at the vutrisiran arm in HELIOS-B, this is approaching the age expected mortality, which is wild. And so we're getting to a point where we're really making a large impact on the disease process itself. There are lots of unanswered questions. We have so much great data, but still much more to learn. How should we monitor patients? Should we monitor patients? And do we think about monitoring the overall disease process itself, or do we think about monitoring the response to therapy once we start them on a stabilizer or a silencer? Is there a role for combination therapy? And can we reverse the disease process itself? Again, the disease tends to decline just more slowly on treatment. And then can we even think about prevention, especially in our carrier population? So this is an expert consensus document which goes over one schema for monitoring disease progression. So thinking about clinical and functional endpoints, laboratory biomarkers, and imaging and ECG. And I typically think about performing some of these tests each time I see a patient, so about every 6 months or so. So reviewing things like New York Heart Association class, if you have the ability KCCQ or 6-minute walk distance, biomarkers, NT-proBNP and troponin, and imaging with echo, as well as ECG. And so this is one paradigm to think about. Is your patient getting worse? But we still don't know exactly what to do with it if your patient is worsening, because that doesn't necessarily mean that we should stop therapy, because we don't know what the counterfactual is. If you stop therapy, they might actually worsen more precipitously. There we go. And then do we think about monitoring response to therapy? So I think this is some of the best data that came out even just earlier this year in terms of TTR monitoring. So again, we talked about stabilizers, they increase TTR, silencers, they reduce TTR levels. And so in the PeerView trial, there was a large increase, again, about 7 of TTR in the acoramidis arm versus placebo. And what's really important is that that increase in TTR that was initially achieved is tied intricately to outcomes. So the higher your TTR response, the better prognosis you have. And then finally, whenever we think about combination therapy, it's important to note that there really are no head-to-head studies of this. So this is some of the only data, the best data that we have about what can we do about combining therapies. So in HELIOS-B, about 40% of patients were started on tafamidis prior to the trial. So this is not a trial comparing tafamidis or vutrisiran or combination therapy. But if you look, vutrisiran was similarly effective regardless of baseline tafamidis use. And so that might make us want to think that we should be doing both therapies. But I love this quote from Dr. Kittleson: "The road to bad outcomes is paved with plausible pathophysiology, surrogate outcomes, and wishful thinking." So we are not there yet.
That's copyrighted, just
Yeah. So not there yet. And I'm actually going to give this and pass this to Dr. Kittleson because this is her brainchild. And I love this way of thinking about how we need to think about choosing a therapeutic.
amazing. I mean, gosh, no one can break it down like Dr. Selvaraj. So thank you so much for that. We have 3 therapies. They all work. So what do you tell patients? You say, congratulations. You live in an era where I can give you a medicine that will preserve your quality of life, not improve it, preserve your quality of life, keep you out of the hospital, and help you live longer. So what do I first ask myself when I meet a patient? Because I passed the first hurdle, I thought of the diagnosis. I passed the second hurdle, I ordered the right tests and I interpreted them in the right way. The third, picking treatment. The first I asked is their end-stage disease. These medicines don't reverse the disease, they just slow or stop progression. So I will have the difficult conversation in a patient who is advanced stage, severely hypotensive, bedridden, class 4 symptoms, bad kidneys, and say, I can't make you better, and I'm not sure if it even makes sense to try to stop making you worse because you're really far gone. That is a hard conversation, but that's our job to do it. It's harder to say no than it is to say yes, but you have to know when to do that. But then, if they are not at that vantage, I've done a good job. I've diagnosed them early enough. I want to freeze them at that part of their disease. I say, is there something your insurance lies back? To date, there is no insurance preference I've discovered with different payers. Almost everyone's Medicare anyway. They're very old. So, but if there is something's cheaper, I'm going for that because all 3 medicines work. We cannot interpret relative superiority because the populations are so different, as Dr. Selvaraj said. But if they have neuropathy, oh, well, there's a compelling reason to pick vutrisiran because we know it works to slow progression, not reverse, slow progression of neuropathy in addition to heart symptoms. And then finally, if they're not too far gone and there isn't one that's cheaper and they don't have neuropathy, I'll say, do you care? Do you want to take a 1 pill a day, a couple pills a day, 4 pills a day? Do you want an injection every 3 months? And then I will pick that option. So cost acts as preference, favor into it. And what's really lovely, I keep on comparing amyloidosis to pulmonary hypertension because pulmonary hypertension is so complicated. I do not understand it. This is not that. These medications are totally well tolerated. I've never had a patient have a side effect. If they have a side effect, I say, it's not this. Let's figure out what else is going on. They're so set it and forget it. It's such a joy to prescribe these medicines. And yes, this is a quotation of mine from the New York Times article that came out a few months ago, where we could be living in an era where patients die not with cardiac amyloidosis instead of from it.
Absolutely. It's such a game changer. Thank you, Dr. Kettleson. So let's talk a little bit about the other therapies that are in the pipeline. So we talked about tafamidis, acoramidis, and vutrisiran. Eplontersen is being studied in CARDIO-TTRansform that is slated to read out in next year. And that'll have an even higher percentage of patients who are on background stabilizer therapy. So again, we'll add more data to this void about what to do about patients in terms of potentially combining treatment options. Gene editing is a really exciting approach. The Magnitude trial is testing a one and done approach that is currently recruiting, potentially at a center near you. And then finally, in terms of reversing the disease process itself, we have antibody therapy, which has been really exciting. And those are slated to read out in the next couple of years as well. So just giving you a glimpse into the future, this is one of the gene editing trials looking at a one and done approach. So it's a single infusion. In this trial of about 36 individuals, you can see there is rapid and sustained reduction in TTR. So about 90% reduction, which is really quite remarkable. And that is completely seen all throughout about 2 years of follow-up. In this population, so this is a single arm study, which is important to note. And so we don't have a placebo arm, but we can see that the KCCQ seems to be relatively stable. And the 6-minute walk test also seems to be relatively stable. And that's a win. Again, stabilization with silencers and stabilizers is the win. And so these are sort of, I'd say, best case scenarios and a potential improvement in New York Heart Association class, especially for the more symptomatic patients. And we'll learn more in a placebo-controlled trial coming up in the future. There are a lot of really exciting science presentations that are going on at HFSA. So I encourage you to look through this. This will be in your slide deck for afterward to see if any of these speak to you. And we encourage you to go ahead and stop by. All right. So getting back to the case. So Leonard was transferred to the emergency room to the ICU. He underwent a TEE cardioversion. We started on amiodarone for maintenance of sinus rhythm afterward. And this significantly improved his symptoms. They trialed a few traditional GDMT medications. However, they were not well tolerated, including metoprolol and vasodilators. They resulted in hypotension. However, he was started successfully on spironolactone as well as an SGLT2 inhibitor. He was discharged with outpatient follow-up for thinking about a specific targeted treatment. And in the outpatient setting, he underwent genetic testing, and this indeed revealed the P.V142I variant. And so genetic testing is a really important part of amyloid care. And it's important for a few reasons. One is we think about prognosis differently in patients who have a specific variant because some of the variants are more neuropathic than others. The other reason is it informs cascade screening. So again, as an autosomal dominant disease, individuals in your family, first-degree relatives need to undergo screening. And this is where I think genetic counseling is super important. So a lot of these individuals are asymptomatic who are family members of the proband, the person who has the disease. And there are implications of genetic screening in terms of life insurance, for example. So having that discussion with somebody who's specifically trained in this is very important. And so let's talk a little bit about V142I. So V142I, as Dr. Kittleson mentioned, is one of the most common variants in the world. So present in about 3.4% of all self-identified Black individuals just in the United States alone. These are some data that we published to look at the risk if you were a carrier for your risk of developing heart failure and dying and what type of heart failure you're developing as well. And so these graphs show that your increased risk for developing heart failure, and that's specifically heart failure hospitalization, so later in the disease course, occurs around the age of 63 for heart failure, and your 10-year risk for mortality increases around 72. And this is actually lower than we previously thought. And these are, again, for late manifestations of the disease, obviously dying, but cardiovascular hospitalization. So the penetrance, we don't understand, we don't quite know, but that's likely to occur at an even earlier stage than what I'm showing you here. There's a large individual and societal impact of the variant. So if we look at an individual carrier, and I'm going to go to the top right of the screen here, an individual carrier, if you're born with the variant compared to a non-carrier, lives in general 2 to 3 years less than a non-carrier. And as we increase and get older, that loss of longevity equates to a substantial reduction in the percent of your remaining time living. So now if we look at the number of individuals who are estimated to be, who are over the age of 50 in the United States and self-identified Black, that's about 13 million people, so older than the age at which people develop cardiac amyloidosis in general. There are about 500,000 carriers, 500,000 carriers in the United States. And if we combine those two numbers, about 2 years of life loss with about 500,000 carriers, that's a million years life lost in the United States and the contemporary living population. So a lot of life at risk here. And so this has begged the question about whether we can prevent the disease in asymptomatic carriers, people in this position who might be identified through cascade screening, for example. And this is going to be a really important study. So this is the ACT early study, which is testing the hypothesis that treatment of asymptomatic carriers prior to the development of cardiac amyloidosis can be delayed or maybe even prevented. So carriers who are within about 10 years of their predicted risk for developing disease are being randomized to acoramidis or placebo. They're followed for about 5 years with an endpoint of developing ATTR, whether that's cardiomyopathy or neuropathy. So let's put this all together. So once we make the diagnosis of cardiac amyloidosis, we need to think about a few different buckets of their treatment. So first is heart failure. So we want to be very cautious with vasodilators as well as beta blockers. MRAs and SGLT inhibitors, again, tend to be pretty well tolerated in this population. Arrhythmias, make sure that they're anticoagulated. I tend to prefer rhythm strategies whenever we can, but it's not always possible in our patients. And then most importantly, probably, is thinking about disease-modifying treatments for our patients. If they have polyneuropathy, vutrisiran is FDA approved for a mixed cardiomyopathy, both the cardiomyopathy as well as the neuropathy component. We want to collaborate with our neurologist as well in this setting. And if they don't have a polyneuropathy, we have several choices: tafamidis, acoramidis, and vutrisiran, which is based upon cost, access, and patient preference. And we don't currently have enough data to support combination therapy. So in sum, ATTR is not as rare as we once thought. It's likely mostly underdiagnosed, but not as rare. There is a lot of age-dependent expression, so that risk increases substantially as we get older with variable penetrance, especially depending upon what variant an individual might be carrying. We need a high index of suspicion since there can be a lot of vague symptoms, especially early in the course, and we need to put on our thinking caps to put all the patient together here. We currently are lucky to have 3 therapies that are all FDA approved, which all decrease the risk of dying from the disease process. And we should think about instituting therapy earlier in the disease to maximize benefit. And again, love this quote from Dr. Kittleson: "We are truly living in an era where you will die with it as opposed to from it." We look forward to taking your questions.
That's right. It's time to stump the professors. We can't wait. So now we will move on to the next part of the session where, if you would like to ask your question live, we'll pass around a mic. But whilst you're getting the courage up to ask your question, we will take some that you've also put together. Oh, no, we have one. Yes. Is that you? Pretty nice to see you. No, you need a microphone, so we're going to run it to you right now so the people in the ether on the virtual world can hear you as well. Go.
So my question is actually about AL amyloid.
Oh, cool.
So if you have a positive fat pad biopsy, and I understand it's less sensitive, there's an argument to still go ahead with a cardiac NMR cardio biopsy because that may change the type of chemotherapy the hematologists, oncologists give. Do you agree with that statement or not?
I will refer you to the HFSA Cardio-Oncology Scientific Statement, which came out in 2024, the supplement, which was about AL amyloidosis. So this is my sense of that situation. You just need tissue is the issue. You've made the diagnosis. If the hematologist tells me, yes, it matters to me if it's in the heart because that is going to change what I do, I will typically use a cardiac MRI in that situation as opposed to an endomyocardial biopsy because I've already got tissue somewhere else. So if the MRI lights up with diffuse LGE classic for amyloidosis, this is much more consistent with AL, especially if they're like a 30 or a 40-year-old where ATTR wasn't on my differential anyway.
Do you feel doing an endomyocardial biopsy in AL amyloid patients is more detrimental in terms of side effects? Do you think they're more at risk for perforation?
I mean, they shouldn't be at more risk for perforation. They're thick, but they might be soft and edematous. My concern is they're so hemodynamically just about to fall off a cliff. I mean, that's been my experience that they go from their time of diagnosis. If you have heart failure symptoms, increased wall thickness, and an abnormal monoclonal protein screen, to me, you're 2 weeks away from having a cardiac arrest. I mean, to me, that's a medical emergency. So if I don't have to stick a little bioptome into their heart, I'd rather not. Do you want to arm wrestle or do you agree?
No, I completely agree with that. We can still arm wrestle if you want.
My frozen shoulder, sorry.
I will lose. No, I completely agree with that. I think there are a lot of case reports, just to be aware that there can be two etiologies. So there's dual cardiomyopathies from AL amyloid and TTR amyloid, which I think requires a very high index of suspicion. I think that's a really tough diagnosis to make. But in general, I think if you can answer it otherwise, I often just message the hematologist and ask the same question. If I get this tissue, will this change your management?
Anyone? Yes, we have another person. Yes.
You have somebody that's stable and beds, and then you inject bone, do you want to and stop it?
Okay, this is the beauty of medicine where you have to be uncomfortable with uncertainty and you have to communicate uncertainty, right? So we know all three of them work against placebo. We have no idea about relative superiority, and we have no idea if switching therapies for X, Y, or Z indications helps patients do better. So I'll tell you my take, and I want to hear Dr. Selvaraj how he talks to patients about it. So I basically tell them that. I say, you're lucky you have therapies that work. There is no harm in switching therapies, but there's no demonstrated benefit. So you have to decide your temperament. What's your constitution? Are you the kind of person for whom lack of harm is good enough? Or are you the kind of person who evidence of benefit is necessary? So that's the conversation I have, but I like to set expectations, meaning you should not expect you will feel dramatically better because none of these medicines reverse disease. And it's very unsatisfying. I can't even tell you which one's better or worse, so how to know if you're progressing. So that's the type of conversation I have. So I typically argue against it, guide them against it, but I'm open to their input in the conversation.
I rarely disagree with Dr. Kittleson, and I'm not going to start now.
Skip to.
But what I would say is that I really need to see the trial where patients who are quote unquote not responding. So going back to that expert consensus document about progression in disease on one therapy, randomize them to an alternative therapy to really see if we should switch. But in the absence of that, I typically don't.
Yes.
I was hoping to ask on cardiac MRI, obviously the diffuse LGE pattern is going to be the more commonly seen and the more accurate. But I was recently had a cardiac MRI come back and it didn't show the diffuse LGE, but it showed increased DCV. And so I wanted to pick your brain on how you handle that situation where it's not a typical finding, but it reads increased DCV may show some infiltrative disease.
I've seen that a lot recently. So at the institution I am, we do a ton of cardiac MRI. And so ECV is a very sensitive marker, and we think it's probably a very sensitive marker, especially in carriers or patients who are early in disease. What I typically have done in that setting is that if I haven't done a PYP or I think it's too early a disease, because you remember PYP was developed in individuals with manifest symptoms in disease. Those are typically individuals with thicker walls. So you're unlikely, especially if you don't have significant LV wall thickness, to get a positive PYP. I repeat the cardiac MRI for progression to see if things are worsening. But I will say that a lot of times whenever I've done a PYP and I just have an elevated ECV, for example, it's usually grade 1, which puts us in this indeterminate zone. And again, if you can still biopsy those individuals. So if you have a very high index of suspicion, I wouldn't be shy about doing that again if we're trying to diagnose the disease early in the disease process. Other thoughts?
Totally agree. Question? Yeah.
Obviously, as you mentioned, there is not a whole lot of data as far as combination therapy, other than perhaps the subgroup of HELIOS. But I'm pretty sure all of us who treat those patients have a handful that we may have tried. I don't know if you have any idea, like what is the overall current data. Is there, I guess at this point, a need for a registry? I know I have 7 patients with combination. Insurance-wise, it's tough to get that. Some of them had neuropathy, and the neurologist had initiated the vutrisiran. And then, so I just wonder, what is the collective information or experience we have, and is there any trend for harm, for example?
Yeah. There will be an ACC scientific statement coming out in October to address the current landscape, including the role of combination therapy. Spoiler alert, I think it's aligned with very much of what we've said. Yeah, I have patients on the same thing too. I think there's clearly, okay, so your first question was, will there ever be a trial to assess this? I think cynically, no, because trials cost hundreds of millions of dollars. And I think semaglutide and tirzepatide kind of regret doing a head-to-head trial. So I don't think that the silencer stabilizer world is going to follow that. A registry, again, it can only tell you so much, but it's better than nothing. So I think that may be the best place we gain insight from in this era.
It will probably be safe and well tolerated. I think that's the best that we're going to know at this point. Whether there's additional efficacy, I think really remains to be seen.
Thank you. That was great, Toggle. My question is regarding family members and the variant when they get positive. So when do you start screening, like the DHCFB should inherit these family members? What do you do with the people who are positive when you know that, okay, somewhere in the mid-60s, they're going to present? Do you doing screening? And if so, I guess we'll see when start therapy. Well, when do you start screening, and what screening do you do?
I think there's a few approaches to this. So there's sort of more general guidelines for screening cardiomyopathies, genetic cardiomyopathies. And so that's usually within 10 degrees of the affected family member's first onset of symptoms. So if the proband demonstrates symptoms at age 60, then you would start at 50 for anyone in the cascade. I also take a variant-specific approach. So we know that there are expected, times of onset for different variants. For example, V142I is rare whenever you're 50 years old. It becomes more common whenever you're 60 or 70 in particular. But I'll usually start screening around the age of somewhere in 45 or 50 at that point. And so screening is also very controversial in terms of how you manage the patient. So if they're a carrier, what do you do? And so, we have a protocol that we develop at our institution about that, about how often we get echoes and PYP scans. PYP scans are not going to change every year. So it doesn't make sense to do a serial PYP scan every single year for a variant carrier, for example.
Yeah. I do, again, when they get to the right age, was it typically an older age, 10 years within, especially for something like for V142I, which is the most common one we see, I do NT-proBNP, high-sensitivity troponin, and echo. And if those things are normal, honestly, you don't have it. And then I tell them come back in a year or two. They typically want to come back every year. They're very activated, but definitely not a PYP unless those less risky, irradiation type of tests are abnormal. Yeah.
I'll also just say that Act Early is developing or has developed their own protocol. And so whenever, I'm actually not sure if that protocol has been published, but whenever that is published, that'll be really good information about one way that screening has been at least a little bit aligned or harmonized.
Yes.
Hi, Ramona Gelserbell. Thank you. Your talk was lovely. Appreciate it. What do you do when you have a patient that's been stable and now think they've progressed, for example, clinically, biomarkers, biological markers, or imaging? Is there any harm in switching to another agent, especially if their insurance will cover?
Okay, so we could have arm wrestled on this point. I didn't jump up while you were talking and tackle you on the stage, but I do not check NT-proBNP, high-sensitivity troponin, 6-minute walk, or any of these markers of potential progression in my patients, because I feel like it's information in a vacuum and everyone gets stressed out and no one knows what to do with the information. Similarly, we do not know if switching therapy makes a difference when you're progressing. It stands to reason it wouldn't, because none of these reverse disease. So at that point, I have the hard conversation with the patient that you are lucky to have lived to the age of 85. But you know what? You're getting worse, and I cannot make you better. So let's focus our energies away from data-free zones and more towards what can we do together to make what time you have left as rewarding as we can, accepting the realities of these limitations. That's my take.
I think one situation where monitoring can make sense is whenever you think about advanced therapies. So for example, if you have an individual who's V142I and they develop significant cardiomyopathy at the age of 67, which is within the transplant timeframe for a lot of institutions, I think then it makes sense to know, because you got to start thinking about having those conversations early. CPET is, I feel like, my best friend, so I use that a lot. Sometimes in the amyloid population when I'm thinking about advanced therapy considerations.
Yeah. I mean, my rule of thumb is anyone who presents with amyloidosis under the age of 70, I'm already worried because that's a little bit early and you got a lot of years ahead of you. So I'm so tuned to class 3 symptoms, VO2 max once a year to look for a TPX, once a year to look for the low VO2 max. And you have a heart failure hospitalization, you bought yourself a transplant eval. Totally agree.
Yep. The other population that can develop symptoms really early in disease are if you're homozygous. So there's about 15,000 individuals in the United States who are homozygous for V142I.
One for the mid talk. What's your average to scenarios where you have a high pretest favorability, elevated neuropathy, where you have a non-diagnostic of like chains, polyclonal pattern, non-diagnostics, and you can focus specs to IP. And in that case, especially discussed for poly can be MRI. So it's more than that before, but as well as the average of those seen.
Do you want me to take it?
Yes. Could you just repeat the last part of the question?
Yes. So the last part is, what will be your average in terms of the evaluation for people who are close to 40 and can do MRI? But hydrogen mobility, LBH, neuropathy, but non-diagnostic specs, PYP, and you have a polyclonal pattern of adherence, so like G's.
I think that is why AI should never take our jobs, because first and foremost, we look at the patient, right? So if the tests don't match the patient, you remember that your pre-test probability guides your post-test probability, and that's a patient I would biopsy, because maybe they have some weird form. There's the one variant that doesn't show up on technetium scans, FeLU, some of P. Yeah. And see how well I did in biochemistry. I was a biochem major. And then the second would be maybe they have the super rare form, like an ApoA something or another, which still maybe you can't do anything about it, but you want to have a diagnosis, so you focus your energies where you need to. So remember, your test result is only as good as your pretest probability. So you don't anchor on the test. You look back at the patient and figure out what to do.
I see your best friend here, and I know it's scary, but I think the complication rate in cardiac amyloidosis is reasonable, and especially whenever it's really important information to be obtained, I think we need to obtain it. And I would say that especially if they're a carrier for other reasons, like they've done cascade screening, there's a family history, I think you got to jump to it.
One last question. So going back to, I think you had a slide looking at progression, if they're on an age and using echo if it's greater than 5%. My understanding of echo is perhaps the most insensitive manner, right? The error rate by echo is 8 to 10%. So how reliable do you go by echo? Why not just get followed by cardiac MRI every year or two?
So I think this gets back to the question of, first of all, should we be monitoring? And I left that as an open-ended question because I actually don't know that we should be doing all of this. I'll say that in my clinical practice, I don't get an echo every 6 months. I do check biomarkers, but I don't get an echo every once in a while because, again, I'm not exactly sure what to do with that information. But to your point, I agree. I mean, I think that some of this is expert consensus, right? But there's a lot of variability in some of this, in some of our measurements. I think cardiac MRI is better, but again, whether we should actually do it in the first place is open for debate.
Great. Thank you.
Thank you all for coming.
Thank you for listening. Remember to download the slides and practice aids and complete the post-test for instant credit. This activity is certified by PVI, PeerView Institute for Medical Education. This activity is supported by an educational grant from BridgeBio Pharma Incorporated. To access all materials for this activity, visit peerview.com/FRU860.